Okay, so hi everybody. Welcome to tonight's webinar. I'm Eileen Michelli and I'm with the Marfan Foundation. This webinar tonight is our 7th addressing COVID-19. We're doing all that we can to keep you up to date on dealing with the pandemic when you have a connective tissue condition. With these webinars, statements from our professional advisory board, and many opportunities for you to ask questions and hear from the experts. So before we get started, I am going to introduce you to Michael Weimer, our President and CEO.
Thanks, Eileen. Good evening, everyone. I really just wanted to combine and say hello, pretty much. I think this is an interesting topic tonight because it's really sort of where we jumped into the water initially when COVID began, and I guess now the spring of 2020. And when I think back about the things that I'm proud of here at the foundation, I think the way we have really managed the information around COVID to make it as available as we could to our communities has been really important and special. And quite honestly, it would not have happened without people like Dr. Kim Eagle, because our medical community have really stepped up and really provided the information that's been so critical in helping people make decisions. And so, Kim, I really appreciate the amount of effort you've put into this personally and professionally. And I think tonight will be another one of those great nights, and folks that are not here will have a chance to see it afterwards, for sure. A couple of quick things that are just bouncing around. Science in Paris, we're going back to the international scene in April. We'll be in Paris for about a week with a number of allied meetings. We have a brand new refreshed research program which has been launched. It has an $800,000 Everest Award given over 4 years, $200,000 per year. Will be the largest grant that we've ever given organizationally. And we have a number of applications that are already, or letters of intent that are in for that. Annual conference, if you've never been to one, we're going to be at Hogue in Newport Beach. First conference in person in, I guess, would be 3 years. We'll be there around July 8th to around July 11th. It's a great opportunity to meet people from the foundation. We have 21 walks if you like to be with community. Our walks are going to be in 21 cities this year. I think only a couple have really happened thus far. Most are happening after the first of the year. Number of virtual special events. But really tonight's another night that's about, our community and helping our patients make good decisions, or their family members and friends that are involved around the issue of COVID. So with that, I'm going to hang around and hear what Dr. Eagle has to say tonight. But Kim, in particular, I really appreciate the leadership you bring to the foundation. So thank you.
Thank you. Thanks, Michael. I appreciate that. And I obviously echo thanks for Kim, because he's really done so much for us on this topic. So the first thing I'm going to do before we hear from Dr. Eagle is I want to share with everybody the latest professional advisory board statement that our Chief Science Officer, Joe Grima, put together with the input from our professional advisory board. This just came out last week. It's on our website now, but I just think it was important to just go through it with you all. So this is an update on COVID-19 and vaccine information for children with Marfan beds, Loeys-Dietz, and related genetic aortic and vascular conditions. So the PAB of the Marfan Foundation continues to recommend that all eligible persons get vaccinated for COVID-19. This includes eligible children and pregnant and lactating individuals. It also includes people who had and recovered from COVID-19 infection. The abundant data indicate that vaccination has very low risk, much lower than COVID-19 infection, and that vaccination is far more likely to prevent serious complications than to cause them. This includes myocarditis, an inflammation of the heart muscle, which has occurred in a very small fraction of the millions of people who have been vaccinated, and which has been mild and easily resolved with treatment in almost every case. Additionally, there's no reason to believe people with genetic aortic and vascular conditions are more at risk of developing myocarditis from the vaccine than any other person. COVID-19 infection is much more likely to injure the heart than vaccination. The position of the PAB remains that the potential benefits of COVID-19 vaccination outweigh potential risks for individuals with Marfan or related conditions. For children 12 and older, they are now able to get the Pfizer COVID-19 vaccine under the FDA's emergency use authorization. These young adolescents will receive the same dose as the adult dose and should have 2 shots spaced 3 weeks apart. For children ages 5 to 12, the Pfizer vaccine received recommendations from the FDA for emergency use authorization and has been recommended by the CDC, and therefore will be available this week. So this was put out last week, so it is available now. The vaccine has been shown to be more than 90% effective in preventing symptomatic infection in young children. Children 5 to 12 years old will be given 1/3 of the adult dose and will also be expected to get 2 doses that are 3 weeks apart. And finally, if there is a winter surge or case numbers remain at current levels, the number of COVID-19 cases, hospitalizations, and deaths in kids would be reduced by vaccination. And vaccinating young adolescents would also help prevent cases in older adults and those at higher risk of getting infected. And as I mentioned, it's at our website, marfan.org. There's an announcement on the homepage about it. So you can click on that and then access the entire statement, which is what I just read to you. So with that, we are going to turn it over to Dr. Kim Eagle. As Michael mentioned, he's been our go-to on COVID research and the latest on what's being recommended. Dr. Eagle is the director of the Frankel Cardiovascular Center at University of Michigan. He's the chair of the GenTech Alliance. He's an advisor to the board of directors of the Marfan Foundation. And he also reviews all the research on COVID for the American College of Cardiology. So he truly is our expert on this condition and all that's going on with it. So with that, I'm going to stop sharing this and I'll give it over to Kim, and then we'll come back with the questions that you all pre-submitted.
Great. Thank you very much for joining us tonight. It's really a privilege for me to be involved with the foundation and helping think about education for our communities. The COVID-19 story continues to evolve almost every week. And therefore, we feel it's important to continue to reach out to the community that's served by the foundation with up-to-date information, scientifically valid, and that you can use in making decisions for yourself, for your loved ones, for your family members, and your friends. Also, I think it's really important to stay educated about COVID-19. It's not going away. It's still here. And there are lots of things we continue to learn that can help shape how we behave in our lives, in our communities, in our homes, in our schools, to try to mitigate the risk of spreading the virus in our communities. What we wanted to do tonight was start with some of the questions that were pre-submitted. And then after we go through those, I'll bring you up to date on some important new information that just came out in the last 10 days related to the status of the Moderna vaccination program. We'll talk about 2 new drugs that are on their way to treat COVID infection. The latest from the CDC in terms of how protected are we if we've been vaccinated. So Eileen, let's go to the questions and then we'll come back to some of these other hot topics.
Okay, great. Let me share my screen again. Okay, so now we're going to get to your questions. Some of you did submit questions that were not related to the topic tonight. So for those, please submit them to our website, marfan.org/ask. And the nurse in our help center, Jan Lynch, will be glad to help you with those. If you have additional questions tonight, put them in the Q&A box, not the chat box, but the Q&A box. And then we'll get to those after we get the ones that are pre-submitted. So let's start with this. How safe are the vaccines for children with Marfan, Loeys-Dietz, VEDS, even Stickler or Beal syndrome?
This is a very important question. And so far, the vaccination program that has been approved for emergency use is the Pfizer BNT vaccine. That vaccine is dosed 1/3 of the normal dose, 3 weeks apart in children aged 5 through 11, and the adult dose for children aged 12 through 18. So far, the statistics suggest that vaccine is incredibly safe and far, far safer than actually getting COVID-19 infection if you're a youngster. Now, it's fair to say that the vaccination trials haven't singled out groups of patients like those with aortic disease or those with other inherited problems, but there's no reason to believe, based on the science we have so far, that individuals who have Loeys-Dietz or Marfan or other types of conditions like these are any less or more likely to benefit from vaccination. And the vaccination is highly recommended.
Great. Is one vaccine safer for children with these conditions than others?
So this is a great question, and one for which we don't yet have an answer. The vaccination studies have been completed for the Pfizer BNT vaccine, and they have the emergency use authorization. The trials of the J&J and the Moderna have not yet been revealed in terms of their outcomes. So for now, the Pfizer BNT vaccine is the one that is available, and I would recommend. In the coming weeks and months, we will see other studies of Moderna and the J&J vaccine in children, and then we'll find out if we have an acceptable alternative. I believe that we will, but currently we have just the one.
Great, thank you. Should a child with Marfan, Loeys-Dietz, BEDS, or related condition who had COVID-19 receive the vaccination?
This is a great question. And it may not be completely intuitive in terms of thinking about this. You might imagine that if you had COVID infection, that would create a natural immunity that would be better, perhaps, than you could get in a vaccine. And actually, the reverse is true. It's very difficult to tell how much immunity is built up after being infected with COVID-19. And on average, the levels of protection are inconsistent and don't reach the levels that we get when we go through the vaccination program. So individuals who've had COVID-19 infection, by and large, probably have some immunity, but the amount of it is hard to know. And so we recommend that they get vaccinated just like everybody else, so that we absolutely know that they're reliably, maximally protected against further COVID infection.
Thank you. If a child with one of these conditions has aortic enlargement, does the recommendation change on the vaccines?
This is also an important question, and I think it gets at the root of some people's fears, and that is, does the inflammation of COVID-19 affect aortic enlargement, or could somehow the virus get into the aortic wall and cause the aorta to expand? And so far, we don't have any evidence that COVID-19 infection has any special effect on people with genetic aortopathy. We don't think that happens. And so whether a child has an enlarged aorta or not, we would want them to be vaccinated.
So the vaccine doesn't affect it either, doesn't affect it differently either?
That's a great question. At this point, we don't have any evidence that the vaccine causes aortas to become inflamed or, God forbid, rupture or tear.
Is the risk of myocarditis something we should worry about, especially in our young boys? Are there statistics on this? And what if the child has aortic enlargement or leaky valves? Does that play a role in maybe increasing the risk of myocarditis?
Yes, our Physicians Advisory Board specifically talked about this in the scientific statement that you read. And what we have seen with COVID infection is that the rate of myocarditis is very low. There's also been fear about myocarditis occurring from the vaccine. That is very rare. Current estimates are that a vaccine-related inflammation of the heart muscle happens in maybe 1 in 10,000 individuals who's been vaccinated. And generally, those patients are only mildly sick and fully recover. We've seen a number of those at our children's programs here at the University of Michigan. And by and large, the vast majority do fine. And so we're continuing to say the risk of that after a vaccine is way, way, way lower than the risk of a serious complication in a person who gets COVID who hasn't been fortunate enough to be vaccinated.
Great answer.
So the enlargement, let me go to the leaky valves.
Sure.
We don't believe that asymptomatic valve dysfunction predisposes a person to do significantly worse if they get COVID-19 or to have a problem with the vaccine. If a person has more advanced heart disease, where they have congestive heart failure symptoms, then that is a person who is considered in a more of a predisposed condition because of the effect it's already had on the heart muscle, perhaps. But in most of our patients who have genetic valve disease who are asymptomatic, that's absolutely not a worry and not a consideration.
Great. Should young men who had the Moderna vaccine for their first dose get the Pfizer vaccine for the second dose to reduce the risk of myocarditis? And similarly, if they had 2 doses of Moderna, should they get a Pfizer booster rather than Moderna for the same reason?
So this is a very good question. First of all, both of these vaccination platforms are excellent. They both, after 2 shots, give us somewhere in the 95% range of protection against serious illness. The FDA and the CDC have wrestled with whether or not we should cross over from one vaccine platform to the other. Essentially, they've given permission for that with these 2 because they're both in the mRNA category. But most of us still recommend that you stay with the original vaccine that you were vaccinated with and get the 2 shots and then the booster at 6 to 8 months, for example. It's probably both safe and effective to cross over. There's no clear evidence yet that either complications or protection are dramatically affected if one would cross over from Pfizer to Moderna or back. Keep in mind, the Moderna vaccine has about 3 times the mRNA effect as the Pfizer. It's also given 4 weeks apart instead of 3. And so the durability of the Moderna vaccine out at 6 months after that second shot has been a little better than what we saw with Pfizer. But after the 3rd shot of both, it looks like the protection against serious infection is in the 95-96% range, which is outstanding.
So while it seems like you might be able to cross over, is it recommended for young men who are worried about myocarditis, or personal opinion?
It is not yet clear that we should recommend crossing over. And I personally don't. I suggest that we stay with the same platform. And until there's compelling evidence to cross over, I don't think that we should infer from some of the observational studies that this is a good idea.
You're the one reading the studies, so that's great to know. Thank you.
You're welcome.
So another question was about pericarditis. So can you just tell us what the difference is between pericarditis and myocarditis? And is there a greater risk of that from the vaccine?
So myocarditis refers to inflammation of the myocardium, that is the heart muscle. Our hearts are surrounded by a sac called the pericardium, and that's just a lining. It's a lining that keeps the heart in its place in the chest as it moves. So inflammation of the lining of the heart is called pericarditis. Inflammation in the muscle itself of the heart is called myocarditis. There have been rare reports of both myocarditis and myopericarditis with COVID infection. There have been rare reports of myocarditis from the vaccines, particularly in younger boys and men, but at a very low rate. And this is very uncommon. Pericarditis is distinctly uncommon.
Okay, thank you. What are the side effects of the vaccine in children for the first and second dose?
So the first thing to say is that children getting the vaccine handle it well. They're tough. And And generally, I would say they waltz through this pretty well. Sore arm, feeling a little fluish, a little achy, maybe a little touch of a fever and or a headache. These are common things that you and I might have experienced with a flu shot, and they're similar with a COVID vaccine. But I would say to you that the level of side effects that children experience is very, very modest.
Good to know. Are boosters, okay, now we're getting into some ethical things people are asking. Are booster shots really necessary when so much of the world's population has not been able to access vaccines due to politics and budgets?
Yeah, this is a great question to ask.
We only ask great questions.
First of all, the notion of being a responsible citizen, not only for our community and our state and our country, but the world, is something that is to be promoted and celebrated. And I love the foundation in its global outreach to try to create education, research, and care equitably around the world for patients with the type of problems that we attack. I would argue that in an individual community, citizenship starts with the community I live in. And that includes my family, includes my friends, might include my schoolmates. So citizenship with COVID starts with the people that I'm going to interact with every day. And the booster has a significant likelihood of reducing the likelihood that I would spread the virus. So after 6 months of 2 shots with Pfizer, for example, the immunity against serious infection has dropped from, say, 95% to less than 80, and will go right up to the mid-90s with that 3rd shot. Moderna is similar. Getting the 3rd shot boosts my immunity back to a level where not only am I less likely to get it, I'm also less likely to harbor the virus and spread it. So I respect people who say, I would rather somebody in a place that hasn't even gotten 1 shot get mine. But the reality of that is it's not going to happen. And I am embracing the notion that the United States is taking the lead in trying to push for vaccination around the world, give free vaccines to countries that don't have the wherewithal to get the vaccine now. Trying to get the whole world to a 70% level of vaccination is the goal. Because if we do that, we're really gonna slow this down.
What are the numbers now worldwide?
Oh gosh, well, it obviously it varies a lot. It's less than 70% in the United States, hovering in the 65 to 70. That varies a lot by community. I live in a community that is probably 75 to 80%. But if you go to a rural area or maybe a poor area with less access to healthcare, the numbers can be down in the 50% range. So the variability across both our country and the world is massive. And of course, the inequities in terms of finance are huge. I'm proud of our country in terms of attacking the global issue. And I believe we are taking the lead in that, which is what we should do.
All right, another question along those same lines. Are booster shots employed by pharmaceutical companies to increase profits?
Yeah, so I understand the nature of this question. And because of the clear evidence that immunity wanes after about 6 months from that 2nd shot, the booster is not a ploy. It's a strategy to get your immunity back to a level closer to 95%, which is what we want. So the booster is very important in terms of getting us to the best place we can be. And if we're vaccinated effectively, we are less likely to lead to further infection in our community and in our family.
So a question just came to me. You're not fully vaccinated after 2 weeks after the 2nd shot. Does the booster kick in right away, or is it 2 weeks after the booster till that really takes effect and you hit that higher immunity level?
It still takes an additional 2 weeks after the booster to get to where we want to be.
Okay. Thank you. So now we're going to go on to some medication questions, and then we're going to go to the questions in the Q&A box that are submitted tonight. A few of these. Is lisinopril, an ACE inhibitor, an effective medication to reduce the risk of getting COVID-19?
This is a question that sort of takes us all the way back to the beginning of COVID. And actually, some of you may remember, this is a couple of years ago, isn't it? There was a report out of, I think, England, reported in the journal Lancet, which raised the question of whether or not angiotensin converting enzyme inhibitors or angiotensin receptor blockers, both of which we use in patients who have genetic aortic disease, might in fact have an effect on how the virus was accessed into the body through receptors in the lungs. It turns out that ACE inhibitors like this drug or angiotensin receptor blockers really don't have a role to play in either protect or harming us with regard to COVID. And we obviously want our patients who are on these drugs to treat either hypertension or risk of aortic enlargement to stay on them.
Okay. Okay, another one of them. Does Losartan interact with the COVID-19 vaccine?
To my knowledge, there's no interaction between the angiotensin receptor blockers like Losartan or the ACE inhibitors like lisinopril and the vaccination effort that we have.
Okay, great. Can you please address the antiviral medications from Merck and Pfizer to treat COVID-19 that have been in the news recently?
Yeah, this is exciting, isn't it? Isn't this an amazing example of the building blocks of science, right? So a few of my patients have said, how could we develop a vaccine program so quickly when the COVID-19 pandemic started? And the answer to that question is, it wasn't quick. The platform to develop mRNA vaccines began after the SARS outbreak in China 20 years ago. And so COVID-19 is a SARS-type virus. So scientists were working on a foundation for vaccination for SARS virus generally, and along came COVID-19, and we were ready for it. So we had 2 decades of research to try to get a vaccination program right using a completely different platform, mRNA, and it worked. Since COVID outbreak, various pharmaceuticals have been working on drugs that are antiviral, essentially antibiotics against viruses. In October, a brief report came out of the United Kingdom on a drug that Merck has been developing, and its name is, I think you pronounce this Lavgevrio. This is a drug, it's called a nucleoside analog. And what it does is it introduces errors into the viral DNA so that it can't replicate. So this is a very interesting, very novel antiviral agent. The company did not release all of the statistics. All they said was that the trial had been stopped. Britain has given them, I believe, regulatory approval to move forward with this drug. And the overall effect, it said, was about a 50% reduction in major adverse events from COVID, like hospitalization and death. It's preliminary, but that was really great news because we didn't have a strong antiviral. And any of you who follow the science regarding the monoclonal antibodies know that although there was some benefit of that strategy, it wasn't nearly the effect of a 50% reduction, for example, in hospitalization or death. Then last week, along came the news from Pfizer, and they have a drug called Paxlobid. This drug also is an oral pill. It's an antiviral agent, and it has a different effect. It's a protease inhibitor, so it inhibits viral replication. The drug from Merck introduces an error into the DNA of the virus so it can't reproduce. This one affects an enzyme that's involved in viral reproduction and basically turns off the ability of the virus to replicate. The early Pfizer studies were released, and the effect was dramatic. There was the overall death rate of 389 patients who got this particular drug was just with no deaths and 3 hospitalizations in that group, 385 who got placebo. So it looks like the drug has about a 90% effectiveness of preventing serious illness and death. So this is a huge advance. It's a drug that's given over 5 days. And now, obviously, Pfizer is working to try to get that produced and made available, particularly to people who have early symptoms within the first 3 or 4 days of symptoms. This looks like a very effective strategy. So I'm really excited about the potential of antiviral therapy as a further step in reducing the seriousness of COVID infection. Another thing that came out this week that's important was published in the New England Journal, and looked at the overall effectiveness of the Moderna vaccination strategy to improve outcomes. The Moderna vaccine was in 30,000 people studied, 93% effective in preventing disease, 98% effective preventing severe disease. And then the question is, what about asymptomatic disease? And this is an important topic for our learning audience. The vaccination programs don't completely prevent our ability to get the virus and carry it. So that effectiveness is in the range of 65%. So it's possible, if we've been vaccinated, we can still get the virus, and we could share the virus even though we don't feel it. And this is why we're continuing to think about masking and social distancing, especially indoors around crowded circumstances in schools, for example, because it's still possible for those of us who've been successfully vaccinated to harbor the virus and share it with somebody else. And I think this part of the vaccination effort has been poorly understood and has led to a lot of consternation with folks out there.
Yeah, because it seems that, is my sound bad? Let's try that again. So it seems that the whole notion of breakthrough infection, I mean, they never said it was going to completely stop infection. It just said they said you're going to reduce serious illness, hospitalizations, and deaths. So those, like, what do you have to say about those people who are getting like the very mild symptoms or they're asymptomatic, but they test positive? So how do we think about that?
So it's such an important further evolution of our knowledge, isn't it? We all hoped that the vaccines would be 95 to 98% effective against preventing death, hospitalization, symptomatic infection, and asymptomatic infection. And the truth is, the vaccines are very good at preventing bad things in folks, but they're not 100% effective in preventing you from getting the virus and harboring it and either being asymptomatic or minimally symptomatic. So until the entire community is vaccinated, we can be sharing the virus even if we've been vaccinated. And some people said, well, gosh, if I got COVID, then the vaccine doesn't work. Well, for you, it might not have prevented getting the infection, but there's a very high chance it reduced the chance that you would get either killed by the virus or get hospitalized and put on a ventilator, for example. So the vaccine programs have been terrific, but they're not 100%.
So speaking of continued spread, can you talk about variants? Where are we with variants now?
So in this country, still, the Delta variant is the dominant force. There have been several other variants that have been described in other parts of the world. Some of them have acted like they might be a little bit more, shall we say, resistant to vaccination. But thankfully, they're not nearly as infectious as Delta. So they haven't come to dominate in the community where they've risen up. So knock on wood, so far, if we're dealing with Delta variant, we still have very effective vaccine programs. And now we have new antiviral therapies coming that look to be effective against different strains also. The drug therapy platforms we talked about from Merck and Pfizer also have this optimistic side note, and that is that type of treatment hopefully would work across the different types of variants of the SARS-CoV-19 virus.
The science is just fascinating, really, really fascinating. So if you have any questions, additional questions, please put them in the Q&A box, because we're going to go over there right now and see what we have. Yeah, great question, James. Does pectus excavatum, when people have an indented chest bone, and a lot of people with Marfan have that, does that propose potential higher COVID complication risk? I mean, we've all heard about the lung problems with COVID. So how does pectus excavatum have any impact or not?
So that's a really that's an interesting question. I've not seen anything scientific on that question. I think in general, if a person has less lung capacity for whatever reason, then they might be more prone to more severe illness if they get COVID-19 with a serious respiratory infection. But I don't know of any data that would support that. And a lot of people who have pectus have other adjustments in their chest wall shape so that their overall lung capacity is either normal or near normal. So if their lung capacity is near normal or normal, then I wouldn't expect them to be at particular risk.
And I would refer people back to our YouTube channel where our previous COVID webinars live, and Dr. Enid Neptune, pulmonologist at Johns Hopkins, who is on our professional advisory board. She's addressed the whole issue of lungs and COVID extensively on our several webinars. So I definitely would refer you back to that. Does anybody else have any questions for tonight? I know we, like I said, this is our 7th webinar, and Dr. Eagle covered so many of the new aspects of what's going on these days. So if anybody else have questions that they'd like to ask, you can put them in the chat box. Well, it seems that you did a great job of addressing all that. We got all the questions that were pre-submitted up here. Okay, so here's a great question. Is there a recommended time for children to wait between COVID and flu shots? Can you get, not even children, but children, but also adults, can you get them at the same time?
Yeah, this does come up quite a bit. I have, and I don't know of a strong basis of science for the answer I'm going to give. I have tended to suggest that people wait a week or two between their flu shot and their COVID shot, just because if they did have a reaction from both of them, having those at the same time seems like it's putting you through more than you need to go through. The truth is, whether that would be something dangerous, I think that's very unlikely that it's dangerous. And if I have a person who's generally reticent to get vaccinated at all, if I have a captive audience, I'm going to probably try to give them both vaccines on the same day if I can. Because COVID, I think, is so much more dangerous than the flu, if a person's not gotten any COVID vaccination yet, I want to start with that and then get them the flu vaccine in a week or two after that, and then schedule their second COVID shot a week or two after that, and they would be in good shape.
What if somebody is facing surgery, elective surgery coming up, and they haven't gotten their COVID vaccine yet, or they're due for their booster? Is it okay to get that right before a surgery, or should they wait?
So it's definitely okay to get it before surgery. Our preference probably would not be to give it the day before, because this could, if they get a postoperative fever, for example, it could complicate the assessment of their postoperative situation. So if we get it to them, 72 hours or more before the scheduled elective operation, I want to do that for sure. But I try not to put it right on the operative date if I can avoid it.
Okay, great. Do mechanical heart valves pose potential higher COVID complication risk?
Great question. We don't think so. Clearly, early on in the pandemic, we were hearing reports of blood clotting disorders, clots in the legs, clots going to the lungs, et cetera. And there was some scientific basis for how the coagulation system might get turned on by COVID. But some of that was the fact that patients with COVID were so sick and stuck in bed, where we see an incidence of deep vein clotting anyway. And at this point, I would say there's no evidence that a patient with a mechanical heart valve is at any higher risk for a problem with COVID infection or vaccination, assuming everything else is fine.
Thank you. Thank you. Any other questions from people who are here tonight? I think we're good. I think we're good.
Want to, before we close, Eileen, is I think as citizens, all of us should imagine that part of our citizenship is to share science with our family, friends, and neighbors, and be willing to stand up for good science in terms of the citizenship around COVID-19. There's been so much misinformation that has been shared through various ways. Clearly, the science around vaccination is profound. Tens of thousands of people have been studied, and the vaccination programs are both effective and safe, way safer than getting COVID-19. And so I encourage my patients to be stewards of good science with their families, with their children, with their loved ones, to try to get the word out. How can we be effective as a community leader in fighting this once in a 100-year problem that our society is facing? And I hope that some of the remarks that we've shared tonight will embolden those who've listened to just be advocates for science. And if there's anything I can do to help that, I'm available through the foundation to try to give further information wherever we can. This is almost like hand-to-hand combat, but the weapon is knowledge. And we need to share this knowledge so that our communities can be healthier and safer.
Very, very well said. I just want to also add to that I'm really proud of the foundation and how we have, really tried to be there for our community. We're trusted by people to give them the information they need from the experts for their condition. And, I can't be more grateful to our professional advisory board. Joe Grima has led the way on the foundation staff, and just in bringing this information to our community and really trying to answer all their questions. It's scary when you have one of these conditions, and just putting a pandemic on top of it, I can't imagine how much scarier that is. So we're just proud that the foundation has been able to do this for people. And if you have more questions tonight after we end this webinar or tomorrow, whenever, submit them to our Help and Resource Center, and I'll post that in a minute, that URL. And then, obviously we're still here to answer your questions. Michael, any thoughts?
Well, lots of thoughts.
Anything related to this topic tonight?
Yeah, Kim, one thing that has been bouncing through my mind is the whole issue of holiday travel. We have Thanksgiving and the year-end holidays coming up, and not only about family travel, but being with elder members of your family. Where are you on those topics at this point in time?
Yeah, that's it's such a tension. There's such hunger to return to a normal life. My feeling is that if people have been vaccinated, I completely understand their intense desire to share holidays together again, and recognize that it's possible that there could be some sharing of the virus and either no symptoms or minimal symptoms that come out of that. Thankfully, the vaccination programs are so effective against serious illness that we do have that luxury, I suppose. But people are all over the map on this, aren't they? Clearly, outdoors is better than indoors. Wearing masks is better than unmasked, but doing that at a Thanksgiving table is tough. I think the place I would really argue for citizenship is if there are vulnerable people that are going to be there that have not been vaccinated. That's a challenge for us, because if they get it, they may die. So we're having a Thanksgiving gathering here with my son and his wife and her family, and there are a couple of people in the family that are sort of anti-vax, and I'm very mindful of them and try how do we position them in our home in such a way that we minimize their exposure. That's something I care about.
Very helpful.
Great advice.
Thank you again.
So before we end tonight, I just want to show you Jan, which I'd love to show you Jan after these webinars because she is so super helpful. Jan Lynch is a nurse who heads our Help and Resource Center. So if you have more questions, send them to Jan through our website, marfan.org/ask. And then I wanted to put up here some other webinars we have coming up and some other opportunities for you all. I'm mostly focused on kids, I think, because I thought a lot of the questions tonight were about kids and vaccines. So on Thursday night, we have a great webinar, Beyond the Selfie. It's a session about body image and life with a connective tissue condition. And then we have an expert and several members of our community with Marfan and Loeys-Dietz who will be on talking about that issue. Our teen chats and teen game nights continue monthly, our monthly kids club. We have a great online event coming up in January, Uncorked, a wine tasting event. It's a great holiday gift idea. I'm going to give it to somebody for holiday gift, and they can come to this wine tasting in January. As Michael mentioned earlier tonight, our Walk for Victory program is heating up. We have in-person in Orlando outside in December, and then we get going again in February in Florida, California, and then all over the place in March and moving forward. So there's just some great events. I know we're still doing these virtual events, but we can't wait to see everybody in person. Finally, speaking of in person and our kids, we have our fingers crossed for our camp program next summer and next spring in Atlanta, Northern California, and Ohio. So we're hoping that the COVID situation permits us to move forward with those. I know we all want to get together again. So that's what we have coming up. And that's all we have for you tonight. So thank you all for being here. We hope to see you again online and in person in the coming year. As Michael mentioned, the annual conference is next summer, and that should be a big celebration if all goes according to plan. So thank you very much, Kim, and thanks for being here again, Michael. And great to see everybody, and we'll see you again next time. Bye-bye.
Thank you. Bye.